friends, if you don't mind, another reminder to make sure that you've put your name along with $10 on the envelope for the opportunity of winning a centrepiece and that brilliant video. For those of us who don't win the video, the opportunity of purchasing same for $10 as you're leaving. And please, if you will, before you head off, go over and have a look at the table over there, the memorabilia, going back nearly 90 years when our club was first established. It really is worth a look-see. My pleasure to introduce the gentleman who's been a member of this Rotary Club since 1974. Has been our guest speaker on no less than 3 occasions. He will in turn introduce our guest speaker on this, the occasion of our 90th birthday. Rotarians and friends, please welcome, if you will, a member of nearly 40 years to do the introductions to the guest speaker, Dr. Royce Cragg.
Thank you, Tony. I find it interesting to note that the first medical member was Dr. Frank Hone, and he was well remembered by people of my day, and I think Bob Hecker would remember how he used to drive his car across any intersection without any regard for what was coming in any other direction. His son was one of my teachers, and it gives me great pleasure to be here today to introduce to you Ian Maddocks. I first met Ian. I'd been travelling the world, visiting many countries to determine how the health services of Papua New Guinea should relate to the great problems the people have. And I arrived in Melbourne on the 1st of September with a request to meet one Ian Maddocks. I didn't know who he was, but he was interviewing me. I wasn't interviewing Ian. He was determining whether he should give the rest of his important years to the people of Papua New Guinea. Was I going to do was the health department going to be a suitable place for him to do the things that he wanted to do? Now, Ian had been up there in 1953 and 1954 as a student and had seen some of the people who were there, and he didn't really know what this young man, Royce Cragg, was, who had taken over from John Gunther. He knew what John had in mind because in 1956, John Gunther had forecast that the medical school of the university would be established in 1971. And Ian, I don't think he knew that this forecast had been made, but I knew it was in a document I had read. Ian's life that's been celebrated in Australia relates to what he has done since he left Papua New Guinea. In the summary that was in the paper circulated to us, the word tropical was mentioned once. There is no question that in Australia Ian's been involved in developing and professing a one-for-one discipline. But in Papua New Guinea, his role was in developing a program related to the problems of the community, of doctors that could serve and help the community as a whole. He went to New Guinea as part of a diaspora of young Christian men, doctors from various universities, and a lot of them from his college from Melbourne, And then in 1974 he became part of a diaspora from New Guinea that came back to various cities in Australia. In Adelaide we had a group that in those days we called the New Guinea Mafia. And Ian came from Melbourne, he had a position in Adelaide, and he was one of the significant members of that group. Ian and I have worked together. We succeeded with others in ensuring that the future doctors of Papua New Guinea would be university graduates and not assistants to Australian doctors. The university and the government, Charles Barnes, had determined that lawyers should be Australian lawyers, like Australian lawyers, but doctors shouldn't. And it was a great victory that we achieved. And when this was achieved, I jumped the fence from government and joined him as one of the foundation professors. I've been fortunate to live where Ian has lived in two of his incarnations, and I've been told not to say this, but we're in a slow race as to who will write the eulogy for the other, as no one knows as much about each of us than both of us. Thank you, Professor Ian.
Your Excellency, President O'Neill, Rotarians and friends, thank you for welcoming me and Diana to this very special Rotary meeting. Thank you for the history. It reminded me that this is the third time I've spoken at your Rotary, because the first time was at the Hotel Australia, so it must have been 30 years ago at least, and it was about nuclear war. On that occasion, I found that it was usual for somebody who had some contact with the speaker to come forward after the speech. I don't know if you do that to me. The only thing they could think of for Maddocks was Test cricket. And so Sir Donald came forward to receive a small memento. Thank you, Roy, for that fulsome introduction. It's good to know that we're on a competition again. You will note that I've been slowed down by recent intimations of decrepitude, but I was keen to share with you this occasion because there are matters important to us. Rotary has a great reputation for thoughtful appreciation of matters that concern our communities. And also looking through Frank O'Neill's excellent document and the history we've heard, it has a reputation for longevity of its members. And that, I think, is an important message for aged care. The award of Senior Australian of the Year 2013 mentioned particularly the work of palliative care, but it stood alongside the award Australian of the Year, which was given to Ita Buckrose for her sterling advocacy in the care of people with dementia, with Alzheimer's disease. It was a significant coincidence because these two things go together. Palliative care began with concepts of hospice, of intensive inpatient care for those dying of cancer. But over the last 3 or more decades, there's been a wider recognition of its work and what it can offer outside of the narrow field of advanced cancer. It's now demanded that it reach out even more widely. Indeed, this year's motto is palliative care is everyone's business. What we want to see is that the particular kind of care that hospices have come restricted to is made available to all who need it, not just those with advanced cancer. One can characterise that care by the phrase patient-centred, by which we mean starting with the needs of care as patient and family see them, not just laying down a diagnosis and a set of prescriptions, but observing, listening, attending, negotiating for what suits this situation, where, when, with whom, what resources will be required to provide care. It's becoming clear that the most significant populations needing this approach, and quite often not getting it, are the burgeoning numbers of elderly and very elderly, and of these, many of the most demanding are those with dementia, which we all risk increasingly as we get older. My interest in care for dying persons began over 40 years ago when I read a moving account by journalist Victor Zorza of the death of his daughter in a small hospice near Oxford. What impressed me was that this young woman, dying of lymphoma, was so well cared for that she was able to look after her parents and take them through the distress and the pain that they were going through as she died. It was an early lesson that good care for the dying has implications for the health of the whole community. After reading Zorza's article, I realised that in most of the major hospitals that I was familiar with, we were not providing adequate care for dying persons. We did not value them. They were failures, embarrassments. Doctors felt they had nothing to offer. It was left to the nurses to provide what comfort they could. Well, things have changed greatly over 40 years. Medicine and lifestyle changes mean we live longer. But uncomfortable dying is still with us. It's with older people. There's still a need for palliative care. Around 1980, a group of us set out to study the unmet needs of patients and persons in southern Adelaide who were dying. We were able to list quite a number. Poor understanding of pain control, little support for home care, no facilities for those close to death, no bereavement support, that sort of thing. We began to learn that there's a great deal that can be done to relieve discomfort and improve well-being in all its domains, physical, mental and spiritual. Things moved slowly as we lobbied for government support, but eventually South Australia established the first academic department with a professor headed by a professor in this discipline, and I was lucky to get that job. We focused on establishing an inpatient hospice for patients with terminal cancer. That's what we knew about. We argued for 6 nursing hours per patient per day, and we were able to provide a high level of care. We set up postgraduate training, available by distance study, and began to advocate widely for people to understand and use palliative care. Very soon, it became apparent that there were many people with advanced cancer in hospitals and homes that couldn't be offered care in a small 15-bed hospice. I drew a diagram, a triangle with 3 H's, hospital, home and hospice, arguing that palliative care needed to be seamless and continuous, offered wherever care was needed, whether it was hospital, home or hospice. In subsequent decades, other limitations have become clearer. Some water. Thank you. Thank you. Palliative care is needed in all advanced diseases: cardiac, respiratory, renal, neurological, and also aged care. Our triangle has to become a square, with aged care the 4th corner. It's here then that the care of dementia links with palliative care. Palliative care, aged care and dementia share values, principles and practices. But while palliative care has received generous funding from the government to support the relatively small numbers who need care for terminal care for cancer. Greater caution is being exercised in funding for the care of the very elderly and those with dementia because they are so many. Palliative care generally has had a good press. It pulls at the heartstrings. The brave fight against cancer towards the end of lasts a fairly short time. It has a predictable course. It can call upon family and community resources for that final journey. The patient's usually responsive, grateful, ready for the care received. The physical and emotional demands for trials of established stroke and dementia can last for years. Interactions can seem tiresome, unrewarding. Modern families can rarely manage to offer a continuity of care for a long period. Kit Wood, a leader in dementia care, noted that persons with dementia commonly experience anxiety and fear, but cannot express it well. Patients are less aware and responsive, less able to engage with carers, particularly casual carers. They really need to be with someone who knows them well and who can touch their inner self, their inner world. Kit Wood called it being present and said it's the basic caring task. It's very similar to what I describe as patient-centeredness. Let me offer a very simple personal example. Many years ago, I drove an elderly aunt from Narracrook to Melbourne to attend the 60th wedding anniversary of her sister. She was cheerfully demented, kept asking anxiously, "Who are you?" "Well, I'm Ian, your nephew." "Ah, where are we going?" "To see Dorothy." "Oh, that's nice." "Who are you?" "Where are we going?" On and on. To distract her, I recalled that she was a pianist who played for her little country church. So I started to sing some hymns, all of which she recalled and joined in. We sang all the way to Melbourne. I was being present for her. In the Parkwood village, where our family lived for 6 years, there were very few old ones and virtually no dementia. Extended families residing in close communities meant that a dependent or aged person had constant companionship and care day and night. In our modern world, most families have limited capacity to work in that way. It's too difficult for one to move back from interstate or another to give up work for a substantial period. Family life is now different. Time and income rule us far more than before. We have to seek professional help to provide care for the very old and demented person nowadays. Well, what strategies might be advanced to bring to aged care and dementia care the principles of patient-centeredness, kindness, freedom from ritual health activities, responsiveness to individual need that we have sought to affirm in the well-funded hospice? Now, there's excellent work going on in science, thinking about how we might delay the onset of ageing, cure cancer, prevent dementia. I'm fearful that any success in such areas will only add to the burden of care we're going to be asked to accept. Some look to the availability of voluntary euthanasia, and I suspect it will be increasingly advocated. Palliative care services and most religious traditions reject that option, and it's clearly proving difficult to establish consistent political support. We hope for an expansion of the aged care workforce with better training and remuneration for those who deliver care. I'm particularly encouraged by the recent provision of packages of support that enable people to receive care in their own homes. A recent study involving many thousands of elderly patients with cancer and their carers found that home palliative care increases the chance of dying at home, reduces the burden of symptoms, and doesn't add to the grief experience of the family. I admire those who work in nursing homes. It's work that calls for great reserves of compassion and patience. Often there are only 2 staff hours per patient per day, compared to the 6 we had in the hospice. And it's demanded of aged care staff that they complete pages of reports so their standards could be monitored. Sometimes one has the impression that the computer screen is getting more attention than the patient. 20 years ago, we pioneered in Adelaide a program to link palliative care support more closely with institutional aged care. And similar studies followed, showing greater confidence and skills in among staff through training and regular palliative care support helps manage discomfort there better, prevents transfers to acute hospitals, and helps patients avoid unnecessary and futile late interventions. I visited an aged care facility recently and was struck by the fact that it was staffed on that shift entirely by young women from Asia. The elderly patients were nearly all Australian born. The young carers shared none of the history important to their patients, and communication was limited. It was therefore very difficult to see any quality of the presence being offered. It can apply to any kind of carers from any background. Unless they're able to feel good about the work and want to be there, they are at risk of what Carolyn Byrne, writing in The Age last weekend, called identity abuse, where residents are no longer treated as people with their own tastes and personalities. Rather, they tend to be treated as a set of tasks that need completing. Feed, medicate, wash, like factory work. Her own mother suffered a range of small but dehumanising indignities. She asked her mother not to be fed bananas because she'd never liked them. And those suffering dementia, she pushed them away when they were offered. The care coordinator allegedly said, "Well, what's the matter? She doesn't remember, she doesn't like them." We need innovation and research, not only into the causes of dementia or possible treatments to defy ageing, but into what structures and with what approaches we can make care more effective. There are examples of a superior care for old age and dementia from which we can learn. Well-planned units where dependent aged are encouraged to live together in small groups, with no more supervision than they really need, helping each other with the capacities they retain, finding dignity and purpose and fellowship in the level of independence that's possible for them. There are dementia units that practice presence with affection and skill, looking to find and strengthen remnants of personality through a thorough knowing of each individual. I invite you to look at the New Yorker for May 18 this year about a small institution in Arizona that calls itself the Beatitudes. It practices Kitwood's principles. Its staff affirm that though demented persons cannot think well, they are not going mad. They can be helped to feel well and avoid anxiety and fear. The Beatitudes offer choice. They avoid unnecessary routines in bathing and eating, encourage bright and comfortable furnishings. They don't have television, minimise drugs, keep chocolate and lollipops on hand. These are simple things, but it remains demanding work. Staff are encouraged to experience for themselves being bathed, being fed, having their teeth brushed. Putting the needs of the resident first also requires good medical supervision because demented people also suffer discomforts. I've been wondering whether we could ask more of our newly retired, because we need more person power in this question of aged and dementia care. People have talked about having video links so that we get in touch with things like, but I think we need human contact. And I've been wondering whether we could ask more of our newly retired, those in their 60s and fit 70s. There are lots of good things happening. One colleague supports a bridge group each week at the local nursing home. He says they're not very good, but it's very important to them. Another provides simple handyman services, changing light bulbs or fixing leaking taps for people on their own at home. There's a multiplicity of voluntary organisations, volunteer people working, but there are still many opportunities. Engage with age is a motto I suggest, looking for increased and better integrated volunteer supports for the very old, helping them remain at home, offering friendship in aged care settings, visiting hospitals, hospices. Not many of us, I suspect, use Facebook or Twitter like the young do, but these regular video links could be useful in all sorts of ways, keeping people in touch and not feeling isolated. I anticipate with great pleasure the scholarship announcement that follows. I'm hoping that Rotary will continue to promote better care of the very old and the demented. We are all of us moving along that road called ageing. In becoming involved in activities that bring us alongside the very elderly and those with various grades of dementia, we can learn a greater sympathy with and understanding of what we might face as individuals. We're becoming qualified to alert the community to a growing need. We're being better prepared to advocate for knowledge, strategies and structures that might augment the care being offered to those nearing the end of the road. Thank you for listening. Engage with age.
Thank you, Ian, for that excellent presentation from a mind that is still as young as it ever was.